to be extracted better. Okay, we quickly move on to the exit strategy. So an overview is that we need to inspect all the calyces, we need to suction all the dust and clots, inspect the pelvic ureteric junction, do a RPG, completely inspect the ureter to make sure that there are no fragments that went alongside the sheath and trapped in the ureter, stent if you need, and then complete with the documentation. So I'm just gonna, for the interest of time, I will need to move on. Okay, so at the end of the case, generally I would document some of these to actually for good documentation purposes. All right. Okay, so the take-home messages for this part of it is that suction in RIRS is a game changer and has made rapid advancement. The use of fans has significantly improved patient outcomes, and proper technique of and understanding of fans is crucial for patient safety. And well-designed fans and ureteroscopes actually improve the efficiency and ergonomics of performing RIRS. Okay, so this is some of the ways that we have pushed boundaries as well as being able to go beyond traditional IRS as well as the residual challenges that we face. So pushing beyond boundaries, I think it's really changed practice in a few ways: access, stone size, operative time, exit strategy, and high risk cases. So for access, there has been a higher primary success rate. So this set of slides has a lot of case examples, but I will just give you the gist of what's important. So generally, even for large renal pelvic stones, we give alpha blockers primarily. We can actually perform primary RRS with very good success rates. So this was with the Innovex scope and Sheath, and it was 100% stone clearance. This is just a stent on post-op day one CT scan. In terms of sheath size usage in our center, we have generally gone down to 10, 12. And also because in at least in this part of Asia, the ureters are generally smaller. I know that in Europe as well as in Australia, 11, 13 and 12, 14 are quite common still. We also have gone down, the average sheath size has come down to around 10.31. The next would be in terms of the operative time. So previously we used to say, okay, RIRS, we don't do it beyond 1 hour. But even now with fans, because it's so safe if done properly, in terms of infection risk, we actually have difficult cases. For example, this lady with severe kyphoscoliosis with large stones both sides. This was on my early learning curve as well. So this patient did take a little bit more time. The total time was 110 on the right side and 68 minutes on the left, but she was completely stone free at the end of the day. And the other thing would be same sitting bilateral IRS. In our center, almost 10 to 15% of cases tend to be bilateral at this point in time. Next is in terms of the stone size. So in terms of guidelines, we generally say 2 centimeters, but even now with more than 2 centimeter stone, so for example, this lady had a 3.5 centimeter partial stack-on. I needed to do RRS for her because anesthetic said she was not fit for PCNL. So we actually managed to clear her in general, but for her, there was a medial angulation of the lower pole that we couldn't clear her stone. But essentially, even for large stone nowadays, we can actually get quite good stone free rate even with RRS alone. Large ureteric stones, this can be challenging cases. I always use a flexible uteroscope and a fans nowadays, even for mid or upper ureteric stones. And this actually can get a very good stone clearance. So this patient was a very large patient, and we needed a combination of lithoclast, lithotripsy, as well as subsequent mopping up with flexible uteroscope and the Innovex fans. Okay, so we'll move on from here. Next is in terms of high-risk cases. So high-risk cases, patients with solitary kidney, for example, in this case, this lady, 74-year-old, she had a large left renal pelvis stone, and with fans, we essentially completely cleared her. So this lady, we use a 7.5 and 11-13, and she's completely stone-free for up to 3 years now. For matrix stones, actually fans do work quite well as well. So in a complete matrix stack horn, we actually did a PCNL, and then subsequently we had to go back in to do some mopping up with the interval RRS. So the interval RRS with the fans actually gives very good evacuation of matrix stones. Last would be the exit strategy. So in our center, because fans has been relatively safe, we have actually moved on to leave quite a few patients actually stent free or just with an overnight ureteric catheter at the end of the case. So some of these cases would tie the utric catheters to the catheter externally and then remove it on post-op day 1. Yep. So this is how the number of stentless and utric catheter cases have actually increased. Okay, so there are residual challenges still despite fans. So these are the 5 things I would say are still quite troubling. So first is low pole stones. Okay, so low pole stones, there can be cases with complex anatomy. For example, this case, we did a PCNL for the patient, and subsequently we needed to go back to do interval RIRS. But because there is, if you can see on this, I highlighted in red, the medial angulation can sometimes be quite difficult, and this can prove challenging even with the most flexible scopes and sheaths. Okay, so the next would be the infundibular anatomy. So I had another patient whereby she had upper pole stones, which looked quite innocuous, but she actually had very acute. On if you see on the RPG, it looks like a T-shaped infundibulum. So even there's a turning radius of the scope and the fans. So if the infundibulum is very narrow and very long, it also makes it hard for the fans to actually reach, especially at the sides, the shoulders of this stone. Next, I would go on. I'll just move on to, sorry, just, okay. The next would be calyceal diverticular stone. Okay, so for calyceal diverticulum, these stones can be quite challenging. Sometimes our fans cannot reach it. So if you can see on the bottom right diagram, this is an image whereby the calyceal opening is very narrow, and only my scope could go in, and my sheath could not go in. So I can only dust to the best of my ability. And the patient does have some residuals at the end. In certain cases, yes, could we have changed it to a direct in-scope suction? Maybe in certain cases. So there may be still a role for DISS in certain cases. The other thing with fans is that previously, at least in our region, we had limited number of 7.5 scopes. And like I said, in the Asian ureters, it tends to be smaller. So we had to, the Busan was actually one of the first few who had a 7.5, and we were using predominantly that. And that was one of the problems we had when we used fans. The last would be in terms of the fans, the variability in terms of the flexibility. So in terms of flexibility, I'll just show an example. So this is another lady with mid and low pole stones. For this case, we use a reborn a sheath as well as a Poussin scope, but we couldn't angle down. You can see that the angle of bending is actually not very good. So quite a lot of low pole stones were actually left in there. So coming to the Innovex 7.5 as well as the fan. So when we started using it, and this is already around 2 years, we actually found that it's quite comparable to what we have currently in our center. So the Boston Little V lead has kind of gone obsolete, at least for us. And the closest competitor is actually the Poussin. So in terms of the comparison, you can see that there's a chart here. And for me, the most important thing is really the flexibility and the deflection angle, which I've at least when we first used it, we felt that the Innovex actually is more flexible than what we previously had. For the access sheaths, this is a comparison of the different sheaths that at least we had back then. And you can actually see that the flexibility, at least anecdotally back then, we actually felt that the Innovex sheath was actually the most flexible at that point in time. And because we had some clinical experience as to, some sheaths and some scopes actually perform better, we actually did a in vitro comparison of the different scopes as well as sheaths across different brands. And we actually recently presented this at AUA. So we actually, on one weekend, we actually put the Innovex as well as a competitor scope to the test. And we actually measured the deflection angles with different fans sheaths. So some of these include the Innovex, the Petra, as well as the Reborn. And what we actually found was that if you look at the bare scope itself, the Innovex actually has a greater deflection angle when we look at it bare. And even when we put a TFL fiber in there, the loss of deflection on the Innovex scope is actually less as well. When we compare it in a particular fan, so for example, we use the Cleopatra 1012 fans, again, the Innovex scope actually deflects better because of the strength of the scope. And when we then put the different sheaths to the test, and when we use the Innovex scope flush to the sheath tip, we can again see that the Innovex sheath actually deflected the best, followed by the Cleopatra and then the Reborn. And this was actually consistent when we actually put in a thulium fiber laser. So because of that, our scope usage trend, at least in our center, has changed quite a bit. And the sheath type has also changed because of what we've actually found. So I'll just end off in terms of RIRS, one case example of RIRS in 2019, and this was done by Dr. Vinit, and in 2024, which was done by me. Surgeon independent is really just the technology has changed. So this lady presented in 2019 and 2024 with relatively similar stones, PUJ stone, and then in 2024, she had an additional low pole component. So in 2019, we actually did a PCN for her, did an antegrade stent, and we actually, Dr. Vinny actually did an RIRS for her with the state of the art back then, the Boston Navigator UAS with the little view. And you can see that the intra images actually show, I'll point out a few things. Back then, our sheath tip actually stayed in the PUJ. The second picture shows the degree of distension while we are doing the surgery. The IRP is high. The third thing is the maximal deflection angle he could reach was only up to this part, and he couldn't deflect down nicely all the way into that lower pole. So post-op, there were residual stones, and that could be the reason why she actually came back in 2024 with sepsis from a PUJ stone as well as a lower pole stone. We stented her in the theater, and subsequently we did a RS for her with a 10, 12, and a 7.5. And you can actually see how the sheath and the scopes actually to be able to bend all the way. So again, pointing out a few things. In today's day and age, our fence tip can get to the stone, and the degree of distension on the top right is actually a lot less. The IRP is really a lot lower. And if this looks familiar, it is quite similar to our in vitro study, which we actually showed that the Innovex sheath actually has the best deflection angle, at least in our experience. So in vitro really matches in vivo. So post-op, she's completely stone and dust-free even on post-op day 1. The take-home messages, fans and miniaturized scopes have arrived and are here to stay. Suction has really changed practice and has challenged the boundaries of traditional IRS. Up-to-date knowledge of equipment is essential for patient outcomes, and residual challenges and fragments still remain. And in time to come, we will know the optimal scope and sheath combination for increased success rates for our patient. So with that, I thank you very much for your kind attention. Again, we apologize that I had to go through a little bit fast at the end, but that was in the hope of leaving some time for some Q&A. And I will just stop sharing now so that I can have a look at the chat to see the questions. So, okay, so the first would be in Switzerland. So hello from Singapore. So the three-way valve, I think I can't answer for Innovex, but I think at least for now, I don't think Innovex has a irrigation system at this point. But I think in individual settings based on local distributors, some, for example, some of the other scope companies that I deal with, some of them actually do then put in like a Turibos or three-way connector in there as part of the package. So it would be good to probably approach your local distributor to see what solution